Good evening, everyone. Welcome to the online webinar sessions hosted by Emergency Department at Yashoda Hospitals, Hyderabad. Today we have an important topic, that is diabetic emergencies. As everyone knows, diabetes is one of the leading causes of morbidity and mortality in the world. Unfortunately, the incidence of diabetes is 10 times higher in India than the Western world. So today we will be discussing diabetic emergencies, which is the most common presentation to the ER, like DKA, HHS, and hypoglycemia. We have Dr. Priyanka, Consultant Emergency Medicine at Manipal Hospitals, Bengaluru. Welcome, ma'am.
Thank you. Please start, sir.
Yeah, please go ahead.
Good evening, everybody. I'd like to thank Srinath sir and Yashoda Hospitals team for giving me this opportunity. It's a huge topic. I'll try to do as much justice as I can to it in the next 1 hour which we have. All right. So diabetes mellitus is a group of common metabolic disorders that share the common phenotype of hyperglycemia. ADA gives you a criteria for the diagnosis of diabetes. It's A1C of more than 6.5% or a fasting plasma glucose of more than 126. When we say fasting, it should be at least for 8 hours. And in our case, in the emergency, we are looking at random plasma glucose, which should be at least more than 200. And patient should come to you with the symptom of hyperglycemia or hyperglycemic crisis. Symptoms of hyperglycemia would include either polyuria or polydipsia essentially, or a 2-hour plasma glucose of more than 200 mg per TL. The etiological classification would include type 1, which has beta cell destruction causing absolute insulin deficiency, or type 2, which is insulin resistant form. Other specific types of diabetes, like due to genetic defects of beta cell function, pancreas, endocrine, drug or chemical induced, and there's also some form of immune mediated diabetes. Gestational diabetes is also important. It occurs in about 7% of the population. The reason we need to know this is about 60% of them have a risk of developing diabetes in the next 20 years. So if you have a lady who's coming to you at about 60, 70 years of age, and you diagnose that patient to be diabetic at that age, you should ask them for a history of gestational diabetes. So the diagnosis requires you to do an oral glucose tolerance test in the pregnant woman, and these are the criteria to diagnose GTM. We can broadly classify emergencies in diabetes into those related to hyperglycemia or hypoglycemia. You can also have emergencies related to the complications of diabetes. Let's start with hyperglycemia, which is the most common thing we encounter in the ER. To diagnose hyperglycemia, you should have a capillary random blood sugar of more than 200 mg per TL. And when you have this reading, you can have a hyperglycemic crisis, which encompasses your diabetic ketoacidosis or hyperglycemic hyperosmolar state, or you can just have a hyperglycemic patient who's not really in crisis. I'll try to combine both diabetic ketoacidosis and HHS together, because the presentations are different, but the management is more or less the same with slight differences in them. Before I go into them, you need to know the basic fundamental of what is fed and what is fasting. So now in normal metabolism, what do? We use glucose. And once you use glucose, the glucose in the body becomes low. So then you get into what is called the fasting state or the catabolic state. When one person enters the fasting state, glucose and ketones are produced. Once glucose and ketones are produced, the glucose in the body becomes high. This high glucose in the body causes stimulation of insulin release. Once insulin is released, it it tells the body that you're in the fed state. And also, it suppresses the action of glucagon, putting an end to the fasting state. This is one of the main reasons why a normal person doesn't go into hypoglycemia. What is DKA? What happens in DKA is there's absolutely no insulin. So when there is no insulin, this part of the fed fasting state gets stuck. So the body thinks that it's perpetually in a fasting state. So there is high glucose release and there's high ketones which are produced. These ketones which are produced cause acidosis and a high anionic gap acidosis. The high glucose causes the patient to urinate excessively, which leads to a state of severe dehydration. So to diagnose DKA, you should have metabolic acidosis, not necessarily acidemia. You should have an anionic gap. The anionic gap elevation is partially or entirely due to ketones essentially. And these ketones are produced because of either an absolute or a relative deficiency to insulin. The common symptoms are, you can have the patient become breathless, nausea, vomiting, abdominal pain. They can be excessively thirsty, or they can come to you with excessive urination. What happens in HHS? There is insulin, but it is not enough insulin. So when we go back to say, you have insulin. Insulin is very little, and this insulin is enough to counter the ketones which are produced, but not to counter the glucose. So the glucose production doubles and triples, but ketonemia not be present. So in HHS, you have hyperglycemia, and this hyperglycemic state causes hyperosmolarity. And this hyperglycemia is relative insufficiency of insulin, and significant ketone production is absent. If anionic gap metabolic acidosis is present, it's usually a lactic acidosis from hypovolemia and hypoperfusion, not due to HHS. So the symptoms in this case are more of lethargy, confusion, dry mouth, excessive thirst, and excessive urination. How would you differentiate between the two? In a classic DKA, there might be a history of type 1 diabetes, and HHS is more common in type 2 diabetes. A DKA patient is usually younger, whereas a HHS patient is usually older. In DKA, the sugar value will be around between 400 to 500, whereas in HHS, the blood glucose will usually be more than 1,000. Significant acidosis in DKA, no acidosis in HHS. This is the hallmark where you differentiate between the two. You'll have prominent ketone production in DKA and no ketone production in HHS. There is no mental state change in DKA, but in classical HHS, there will be noticeable mental state change. Moderate hypovolemia in DKA, and in HHS, you will have severe hypovolemia. What are the precipitating factors? There is some degree of overlap when it comes to the precipitation of the etiological causes. And commonly pneumonia can precipitate DKA or HHS. The second is the myocardial infarction. That's why you need to have ECG for all such cases. Another precipitating factor, GI hemorrhage is a factor, pulmonary embolism, and vascular. There are certain factors again be common for both. There are certain which are exclusively to DKA, that is, if they omit or they reduce the daily insulin injection in substance uses like cocaine, medications like steroids, thiazides, and antipsychotics. In case of major trauma and post-surgical, DKA is more common. Whereas HHS is more common for following acute renal insufficiency, severe burns. It can occur in peritoneal and hemodialysis patients, patients with rhabdomyolysis, and also in pregnancy. Let's go through 3 cases, and I can tell you eventually whether it's DKA, HHS, or neither. So we have a case 1. We have a 47-year-old guy with diabetes on insulin, comes to us with nausea, vomiting, diarrhea, and abdominal pain. He has missed his insulin dose yesterday. Labs show sodium is 133, potassium 3.5, chloride is 107/60. Urea is 34, creatinine is a little on the higher side, 2.6, and the sugars are 407. ABG is pending, and the urine analysis shows class ketones. So in this case, what happens? The bicarbonate is low. So when the bicarbonate is low, metabolic acidosis is present. But the anionic gap, when you calculate it, comes to only 10, which means there is no high anionic gap. Serum osmoles are all normal. So in this case, it is neither. It's neither DKA or not HHS. He's probably got metabolic acidosis because he's having vomiting and diarrhea. But there is no anionic gap which is positive and the osmolarity is normal. So you cannot classify him to be either DKA or HHS. Similarly, we can have a similar case scenario of a 24-year-old guy on insulin. Same kind of presentation, he's also missed his insulin. In this scenario, his sodium is 136, chloride 95. His bicarb is 25. His urea is 15, creat is 1.2, and his blood glucose is 392. This is his ABG picture, which shows a pH of 7.38, PCO2 of 38, PO2 of 95, and a bicarb of 25. Now the bicarb is normal. So will you say metabolic acidosis is present? Metabolic acidosis is actually present because if you do the calculations in the blood class analysis, it's a mixed picture. So initially he had diarrhea, which created a metabolic alkalosis. And once he started vomiting, the metabolic acidosis set in. And because of the alkalosis with acidosis, the pH kind of normalized. But if you calculate the anionic gap, the anion gap comes to 16, which means it's a high anionic gap metabolic acidosis, even though it's a mixed picture on the ABG. And the serum osmoles are normal. So even though this patient is having a mixed picture on the gas, you still say that he is in DKA. So it's very, very important to interpret the ABG and to calculate and see whether it's a primary acidosis, mixed or primary alkalosis, because this can be easily missed looking at the pH. If you have, this is another case, which is an 81-year-old gentleman with diabetes. He's also having atrial flutter, CAD, hypertension, referred for chest pain, mental state change, and low BP. ECG shows atrial fibrillation, and the rate and pain results with IV fluids. His sodium is 151. His chloride is 111. His bicarb is 26, urea 65, creat 1.6. But the sugar level is 916 and lactates are 4. So his bicarbonate is normal. Metabolic acidosis is absent. Anionic gap is high, it's 40. There is a high anionic gap, but at the same time, the serum osmoles are extremely high. So this shows that this patient is in a hyperglycemic hyperosmolar state. What are your targets of therapy in a DKA and HHS? Now, we went through this whole graph of how the patient, how one goes from a fed state to fasting stage and how insulin acts to keep a patient in DKA only in the fasting state, where in DKA there's absolutely no insulin. So what are we worried about? In this fasting state, where there are high glucose and ketones produced, we are looking at uncontrolled acid production and uncontrolled hyperglycemia. In this scenario, we are worried about life-threatening aortic diuresis or shock and life-threatening metabolic acidosis. And these two as a combination can clearly cause death, and these two are easily reversible. In HHS, on the other hand, you have high glucose, which causes uncontrolled hyperglycemia, gives me an osmotic diuresis state, causes shock and death. The target of therapy would be hypovolemia, essentially in both the cases, and management of acidosis in DKA. Hyperglycemia, electrolyte disorders, provoking disease, all these take a backseat. The primary goals of treatment would be to correct the hypovolemia and the acidosis. So let's look at hypovolemia. We all know that the total body fluid is 60% of the body weight. So 2/3, 1/3 becomes ICF and ECF. And in the extracellular fluid, we have it in a 3:1 ratio of interstitial fluid and intravascular fluid. This intravascular fluid is your immediate resuscitation goal. This is what gets depleted in both DKA and in HHS. So when we give isotonic fluid, which is your normal saline, the distribution is the same, and only 300 ml reaches the intravascular fluid. But if you give water or a 5% dextrose, the amount which reaches the intravascular space is even lesser. Hence, the primary fluid of choice in a patient with DKA is isotonic saline, irrespective of the sodium. So the fluid options which we have could be saline, could be a half and half, or a bicarb drip, or a lactated ringers. So saline is predominantly the fluid of choice, but you wouldn't want to give about 5 to 6 liters of saline and push the patient into hyperchloremic state. Hence, after giving about 1 to 2 liters and restoring volume status, it's best to shift to 0.45% saline. Bicarb drip is usually not advocated, and ringer lactate can be given, but you need to keep a watch on the potassium. So initial fluid would be isotonic IV fluid. Goals would be normalizing BP, heart rate, and achieving a urine output. So saline first, but change to RL or half NS with bicarb after several liters. Use insulin to stop osmotic diuresis. And once hemodynamically stable, hypotonic IV fluids with potassium to replace free water and potassium deficits. Now coming to acidosis. Acidosis is seen in PK only. So we measure pH. And our goal is to shut off ketogenesis. So that's done by starting an insulin drip. Atropine is the insulin which is used, and you start an infusion at 0.1 unit per hour. Hourly blood glucose checks are advised. Titrate the insulin drip to get a blood glucose drop of at least 50 to 70 mg per hour. If the blood glucose is too low, please add dextrose, continue the insulin, but do not stop the insulin infusion till you're able to control the anionic gap and the ketoacidosis. Monitor the anionic gap every 4 hourly, which means have serial ABGs which are done every 4 hours. Consider IV bicarbonate only if the pH is less than 7 or the bicarb is less than 10. In hyperglycemia, in HH's case, we are measuring both blood glucose and osmolarity, and the goal is to shut off osmotic diuresis. Here also the insulin drip dose will be the same, 0.1 unit per kg per hour with hourly blood glucose checks. But titrate the insulin drip similarly at the rate of 50 to 70 mg per dl per hour. But unlike DK in HHS, if the blood glucose drops to less than 100, you have to stop the insulin. You do not supplement with dextrose. Consider IV bicarbonate again if the pH is less than 7 or the bicarb is less than 10. DK versus HHS. What is important in DK is you have life-threatening acidosis, less hypovolemia. So the goal is more of insulin with fluid. In HHS, it's life-threatening hypovolemia, no acidosis. So the goal is fluid, and also insulin to control the sugars. Sodium management. So on presentation, measured serum sodium may either be high, normal, or low. So regardless of the sodium level, free water deficit should be presumed. And during treatment, the measured serum sodium may rise. So when hemodynamic instability is resolved, it's advised to change to hypotonic IV fluids or tell the patient to take oral free water. Potassium management. Potassium is usually elevated on presentation due to cellular shifts and because there's a deficiency of insulin. But generally, the whole body potassium is usually depleted. But again, when you're correcting acidosis, potassium tends to move back into the cell and the serum level rapidly falls. So ringer lactate contains potassium, so it may be used as an IV fluid, and it tends to kind of bring up the potassium. So if the initial is more than 5.2, initiate regular insulin bolus. Bolus insulin is removed, but intentionally advises to give the bolus, but the rate infusion is usually at the rate of 0.1 unit per kg per hour. And repeat the potassium in 2 hours. But if the potassium is between 3.3 and 5.2, then it's better to supplement 20 to 30 milliequivalent of potassium to each liter of fluid and continue the drip rate at 0.1 unit per kg. If the initial potassium is less than 3.3, the idea is to first bring up the potassium to more than 3.3 and then start insulin drip. Underlying disorder workup. The number one cause would be non-compliance with prescribed therapy. So talk to the patient. Second is infection. So look for the history, ask them for infectious sources, CBC blood cultures, urine analysis culture, chest x-ray, antibiotics if required. And also please rule out acute MI. So ECG, creatinine kinase and troponins are very important. Transitioning to the floor. So fluid resuscitation should be continued to the patient is hemodynamically stable. When would you stop the insulin drip? In a DKA patient, you will stop the insulin drip when the anion gap is closed and when the ketosis is resolved. In HHS, you will stop it when the blood glucose levels are controlled. Continue frequent electrolyte until anionic gap is closed or patient is eating well and not requiring much replacement. Subcutaneous insulin should be initiated 1 to 2 hours before turning off the drip. For DKA patients, it's preferred to use Lantus or NPH insulin is usually given. I would like to mention about DKA and HHS in hemodialysis patients because this is quite a common presentation in the ER. So life-threatening acidosis or hyperosmotic state still occurs, but hypovolemia and electrolyte disorders may not be that clear depending on the residual renal function. They will need less fluid and electrolyte replacement. And if you aggressively give fluid and electrolyte replacement, it will result in acute dialysis. Bicarbonate may be normal depending on the last hemodialysis of the patient. Hyponatremia is usually present and may be severe. If you do dialysis, you can have rapid glucose drops. Hence, insulin therapy should be cautiously used in hemodialysis patients. So what if it is not DKA or HHS? Then you need to ask yourself, is the patient critically ill? If the patient is critically ill, insulin infusion should be initiated. The goal is to maintain the sugar level between 140 to 180 mg per dl. It is not required to go with a textbook definition and try to bring the sugar level up to less than 110 because it tends to cause increased mortality and morbidity. If the patient is not critically ill, you need to decide whether you're hospitalizing the patient or sending the patient home. If you're sending the patient home, you can initiate oral antihypoglycemic agents and send the patient. If you're hospitalizing the patient, subcutaneous insulin is preferred. The goal is again the same, 140 to 180 mg per dl. Sliding scale is initiated in many institutions. You can start sliding scale insulin, but it's not recommended for use for more than 24 hours of hospitalization. Following 24 hours, you switch to basal bolus. So using sliding scale, you try to determine what was the total amount of insulin used in the last 24 hours. So let's say your patient required 24 units of insulin in the last 24 hours. You divide that by 2. You give 12 units of long-acting insulin like Becil or Lantus once a day, and the remaining will be 12 units. You divide that into 3 doses, and you give the patient 4 units of a short-acting insulin like Atropine 3 times a day subcutaneous. You serially monitor the sugar and adjust the doses of Atropine and Lantus to maintain the patient's sugars between 140 to 180 mg per dl. Coming to the other diabetic emergency, hypoglycemia. Hypoglycemia is often a complication of the treatment of diabetes mellitus. There is no fixed laboratory definition of hypoglycemia. In a non-diabetic patient, if you have symptoms consistent with the diagnosis, symptoms associated with the low glucose level and resolution with glucose administration, you can give a diagnosis of hypoglycemia. In a diabetic patient, it's more complex, and a plasma glucose concentration of less than 70 mg per dl is usually accepted as a universal threshold for diagnosing hypoglycemia. So what is the pathophysiology? What happens when the blood sugar falls less than 80, insulin gets secreted. That's a neuroadrenergic stimulation. And when it's less than 65, there's an increase in glucagon, epinephrine, and the growth hormone cortisol. As the sugar levels keep dropping, the glucose autoregulation takes a hit, neuroglycopenia sets in, patient goes into lethargy, coma, convulsion, and less than 20 and 10, there's permanent damage and death. So what happens in a normal subject? We are able to suppress the insulin release. So we are able to increase the counter-regulatory hormones. So we know when we get hypoglycemic and we act on it. What happens in a diabetic patient? The protective response is impaired. So insulin release cannot turn off, and the effectiveness of counter-regulation is reduced. So the most common cause is what we call hypoglycemic unawareness, which is due to hypoglycemia-associated autonomic failure. So in early type 2 diabetes, there's a relative beta cell failure, which causes isolated episodes of hypoglycemia. But in advanced type 2 diabetes and in type 1 diabetic patient, there's absolute beta cell failure. So this causes multiple episodes of hypoglycemia, which are stimulated in exercise also by sleep and there's an attenuated sympathoadrenal response, decreased adrenomedullary epinephrine and decreased sympathetic neural responses, which causes defective glucose counter regulation and recurrent hypoglycemia. So you can diagnose it based on fasting hypoglycemia or postprandial hypoglycemia. In fasting, it's usually underproduction or overuse. Underproduction can happen due to alcoholism, organ failure, hepatic failure, uremia, endocrine deficiencies, or drugs. Overutilization happens following prolonged exercise, severe sepsis, in case of some mesenchymal tumors, and in hyperinsulinism, which is caused due to drugs, autoimmune insulin syndrome, insulin OMAs, or insulin receptor antibodies. Postprandial is when you have a patient presenting to you with hypoglycemia within 5 hours following having eaten a food. This usually happens following any recent GI surgeries. If there's inborn error of metabolism, can be functional, and it can also be an early presentation of prediabetes. Drugs are very commonly cause hypoglycemia. The most common are insulin, sulfonylureas, and alcohol. Sulfonamides, not that much. Salicylates, quinine, pentamidine, and beta blockers are also known to cause hypoglycemia. What would you do in a hypoglycemic patient? If the patient is alert and able to drink, you can give oral glucose. You can give 15 to 20 grams of rapidly acting carbohydrate. If the patient is alert, awake, unable to swallow, as in post-op recent surgical patients, you can give 20 ml of 50% dextrose IV, followed by 5% dextrose in water at 100 ml per hour. If the patient has altered level of consciousness, then IV has to be started, but you give it at a higher rate. You give about 25 ml of 50% dextrose and continue 5% dextrose. If the patient has altered consciousness and no IV access, then glucagon is given. You give 1 mg IM twice. Glucagon is preferably given in the gluteal region or in the inner aspect of thighs. Glucagon should not be administered in the upper limbs. Recheck blood glucose every 15 minutes until at least it comes up to 80 milligrams per deciliter, or if the patient is altered, the patient regains consciousness. If the patient fails to respond to initial glucose treatment, then you will have to suspect sepsis, toxin, insulinoma, hepatic failure, or adrenal insufficiency. These are the top 5 causes of failure to respond to initial IV dextrose. I'd like to specially mention about sulfonylurea-induced hypoglycemia, because this is a very common ED presentation. It's challenging to manage because the patient will have persistent of hypoepisode. The octreotide is a somatostatin analog, and it is able to suppress insulin secretion immediately, and it tends to negate the effect of sulfonylurea. It is believed to be superior to glucose and diazoxide. The recommendation is a single 50 to 100 microgram after a single hypoglycemic episode. You can even give serial subcutaneous injections every 6 to 8 hours, or you can even start a constant IV infusion of 125 mg per hour after a second hypoglycemic episode. But remember that octreotide should be given only after initial glucose therapy and when the response to dextrose is inadequate. It's primarily used to reduce recurrent hypoglycemia. What would you do for a hypoglycemic patient? You should consider admission if hypoglycemia is due to drugs, if there is an underlying infection or end organ failure. But if the patient is having an isolated episode of accidental hypoglycemia, not resulting from drugs, and the patient has reliable follow-up with somebody to take care of them at home, you can discharge after 4-hour observation. I'd like to mention a few complications-related emergencies which we see in the ER. The first is diabetic foot ulcer. So we can classify diabetic foot ulcers into non-limb threatening, limb-threatening, and life-threatening foot ulcers. A non-limb threatening ulcer would be infection, no systemic toxicity, no ischemic changes, no bone or joint involvement, it is not probe to bone. So the treatment would be outpatient management with follow-up in 24 to 72 hours, debride all the necrotic tissue and callus, take good care of the wound, give a dressing, start an antibiotic, send the patient home. If it's limb threatening, how would you know? If it's more than 2 centimeters of cellulitis or inflammation, if there's associated ascending lymphangitis, if there is a deep, full thickness ulceration or abscess, if there's a large area of necrotic tissue, if there's involvement of deep structures, bone, gangrene adjacent to the ulcer, or critically lower extremity ischemia. In such limb-threatening ulcers, you need to admit the patient. Surgical debridement is advised. You need to explore and drain the deep abscess, empiric antibiotic coverage, and osteomyelitis has to be surgically resected. Life-threatening is when they have systemic symptoms, sepsis, altered mental status, and metabolic abnormalities. In such cases, the patients will require ICU admission, ABC management and resuscitation as appropriate, surgical consult for active wound management and source control. Now, in a non-diabetic adult who comes to you with emergency, I would like to evaluate for the presence of diabetes with maybe HbA1c if I see the patient having soft tissue infections like carbuncles, cellulitis, or non-healing ulcers and coming to the ER with recurrent infections. In emphysematous infections like cholelithiasis and pyelonephritis, these are diabetes-defining infections. So if you have a patient coming to you with emphysematous cholelithiasis or emphysematous pyelonephritis, you need to screen the patient for presence of diabetes. Fungal infections, mucormycosis and candidiasis. Patients present you mainly with fungal infection, and when you check the sugar might be 300 or 350. And when you go back and ask them for a history, they may tell you that they are polyuric or polydipsic. The first presentation may not be symptoms due to diabetes. The first presentation may be one of these, which makes them come to the hospital or the ER. So to conclude, I would say capillary blood glucose has been considered the fifth vital sign. Irrespective of hyper or hypoglycemia, it's very important to look for the precipitating cause. Serial monitoring of sugar values is important. Once you do the diagnosis, you tend to forget monitoring. It's easily missed. So it's very important to monitor the sugar values serially, at least hourly, as long as the patient is in the ER. Screen all non-diabetic adults, as diabetes is considered to be endemic, and it can be ER presentation might be the first presentation for many patients to the hospital. Thank you. I'll be happy to take questions if there are.
Thank you, ma'am. We have few questions. Can you hear me?
Yes, I can hear you.
Yeah, ma'am. The first question is, what is the role of K-bine sachets?
In a patient who's coming to you with DK or HHS, giving them oral K-bine sachet will not really be beneficial. It's better to start IV potassium and put the patient in a IV in an intensive care unit. And if they're already coming to you with vomiting and loose motions, you give them K-bine. K-bine is not very easily tolerated. It's GI toxic, so it's not recommended.
Okay, ma'am. The next question is, if patient sugar levels are 350, how much units of insulin we want to give? Is there any dose per kg?
Yeah,
and either it is long acting or short acting.
In the ER, short-acting insulin is preferred because monitoring is easy. So Actrapid is what is preferred, and the dose is 0.1 unit per kg body weight if you're starting insulin infusion.
Yeah, ma'am. The next question is, what treatment should we prefer for DKA patient after discharge, either insulin or oral hypoglycemics?
So it depends on if you're able to find out the precipitating cause. If you're able to find out the precipitating cause and treat that, and you're sending the patient is able to tolerate enough orally well, it's better to overlap. Start an oral diabetic agent with some long-acting insulin and slowly taper the insulin if you're able to get good control with the oral drug.
Yeah. The last question is, what about IO access for hypoglycemic resuscitative therapy?
There's not, if you're not getting an IV line and you're getting only an IO access, then I think you can go for it. But IV is usually preferred. You can go for a central line.
Yeah, okay, ma'am. That's it with the questions. We have a few more questions, ma'am. How you give potassium in peripheral and central line, precisely dilution?
We do not give potassium in peripheral line. Central line is preferred. You don't give more than 10 milliequivalents per hour. So potassium comes as a ampule, 20 milliequivalent ampule. So depending on how much you'd like to give the patient, you will start 40 milliequivalents, which is 2 amps in about 500 ml of NS. And if you start at 125 cc per hour, that equates to 10 milliequivalents per hour. But if you're having a patient whom you want to give lesser fluids, like in CCF, then you give 20 milliequivalents in 100 ml NS, and you start at 50 cc per hour, which is less than half the dose of the 125 ml.
The next question is, what is the management of DK in a CCF patient?
Right. That's a very good question. So DK and CCF, you need to prioritize airway breathing circulation first. If the patient is very breathless, you intubate the patient, be a little cautious on the fluids, and go more on insulin.
Yeah. And other question is, what is the dilution of potassium correction?
I think we just did that just now. The same thing, 10 milliequivalents per hour. That is, you load 40 milliequivalents in 500 ml NS and give it at 125 cc per hour.
Yeah, thank you, ma'am. That's it with the questions. I think that's such a very good presentation, and it's clear to everyone.
Thank you.
Thank you so much, ma'am.
Thank you very much, Dr. Priyanka. It was very, very great presentation, and I hope all the residents who are listening are well beneficial for this. Thank you.
Thank you, sir.